Topic number 6: X-ray diagnostics of emergency conditions in diseases of the digestive system. Lecturer Shevchenko Alexander, Baltic Federal University, Medical Institute, Kaliningrad, 2020. Main methods of radiological examination of gastrointestinal tract. First of all, it's of course X-ray, but we can add some barium per os, and we can see the fluoroscopy. Or we can give the patient barium enema and then add some air to the bowels of the patient, and we have double contrast fluoroscopy or irrigoscopy. We have CT scan, MRI, ultrasound, PET and SPECT scan. First of all, gastrointestinal tract begins from the mouth, but we didn't talk in the context of the general surgery about mouth. We first of all speak about esophagus, because we deal with it, but we didn't deal with the mouth. So first disease that you can see, it's Achalasia. Achalasia or esophagus spasm. We have see here esophagus, and we see the spasm of the distal portion of the esophagus here and here. This sign is called bird beak. So we see high width of the esophagus, and here we see the spasm. Another one pathology of the esophagus is Zenker's diverticula. Diverticula of the upper portion of the esophagus we can see as a bubble filled with the contrast on the fluoroscopy. And this is frontal view. If we have diverticula in the middle or lower part of the esophagus, we have seen this picture. Sometimes we deal with caustic burns of the esophagus. Sometimes it's acid, sometimes it's base. So we see the picture which we can see below. We have very thin line which must be more wide. Here we cannot see the dome of the diaphragm, but it's placed here, and this is a part of the stomach which now in the pleural cavity. So, bowel gas pattern. Any part of the bowel may be visible if it contains gas air within the lumen. Gas air is of low density and forms a natural contrast against surrounding denser soft tissues. It is often difficult to differentiate between normal small and large bowel, but this often becomes easier when the bowel is abnormally distended. The upper limit of normal diameter of the bowel is generally accepted as 3 cm for the small bowel, 6 cm for the colon, and 9 cm for the cecum. 3-6-9 rule. So 3 for small bowel, 6 for large bowel, and 9 for cecum. Stomach. The stomach may be visible if it contains gas or air. It is not visible if it is either completely empty or fluid filled. So this is the stomach. Ram's horn sign. Less than 4% patients of Crohn's disease have involvement of the stomach and duodenum. It will cause conical narrowing, tubular shape, and limited descendability of the stomach. The antrum is the gastric region most frequently involved. This may give the stomach as unusual shape resembling the horn of a ram. But you must understand, this is not always a picture of a disease, because sometimes you can see a wave of peristalsis. So it can be normal. You must re-examine this patient if you see this picture. Leather bottle stomach. A leather bottle appearance, also known as linitis plastica. The differential for the appearance of a leather bottle stomach includes sclerosis metastasis from lung, colon, and pancreatic carcinomas, lymphoma, Crohn's disease, sarcoidosis, and syphilis. Typically, the stomach is diffusely thickened with a small lumen. Gastric ulcer. We see here. Small bowel. Duodenum to terminal ileum. Generally, the small bowel lies centrally within the abdomen. The valvular convolutions, also called plica circularis, are thin, circular folds of mucosa, some of which are circumferential and are seen on an X-ray to pass across the full width of the lumen. And you must understand, small bowel must be 3 centimeters in the width. Large bowel. The retroperitoneal structures of the colon, ascending colon, descending colon, and rectum are relatively constant in position. These are often more readily identified than the transverse colon or sigmoid colon, which are more variable in position. If visible, the cecum is often the widest segment. It too has a variable position, but is most often confined to the right iliac fossa. The longitudinal muscles, tenia coli, and circular muscles of the colon form circulations called haustra, which have characteristic radiographic appearance. Another characteristic feature of large bowel is that it contains feces. This has a mottled appearance due to its part of gaseous content. Normal large bowel. We have gas pattern with feces. This is hepatic flexure. This is part of the transverse colon. We can see haustra, splenic flexure of the colon. This is part we call ascending colon. This is part we call descending colon. Soft tissue on the X-ray. Abdominal X-ray provide a limited means of assessment of soft tissue structures, although plain radiographs of the abdomen provide limited detail of the abdominal organs. Occasionally, a knowledge of their normal appearance will allow identification of abnormalities. Soft tissue organs visible on abnormal X-rays include the liver, spleen, kidneys, psoas muscles, bladder within pelvis, and lung bases within thorax. Liver on abdominal X-ray. The liver lies in the right upper quadrant and seen as a blend area of gray on abdominal X-ray. The superior edge of the liver forms the right hemidiaphragm contour arrowhead. In this patient, the breast shadow red line overlies the liver, and markings of the right lung are visible behind the liver. The gallbladder is only rarely visible on an abdominal X-ray. Its position is very variable. This patient had a cholecystectomy. The clips mark the previous location of the gallbladder. Lung bases on abdominal X-ray. The lung bases, which pass behind the liver and diaphragm in the posterior sulcus of the thorax, may be visible on some abdominal X-rays. It is worth checking the lung bases, as some patients with lung pathology present with abdominal symptoms. If there is consolidation suspected from the abdominal X-ray, then a review of the patient's respiratory system is necessary. So here we see costophrenic angle. Psoas edges on abdominal X-ray. The psoas muscles arise from the transverse processes of the lumbar vertebra arrowheads and combine with the iliacus muscles. Together, these powerful muscles from the iliopsoas tendon, which attach the lesser trochanter to the femur, the iliopsoas muscles are the flexors of the hip. An abdominal X-ray often demonstrates the lateral edge of the psoas muscles as a near straight line. The iliac muscles are not visible, but they lie over the iliac bones of the pelvis, which precisely on this picture. Kidneys on abdominal X-ray. Natural contrast between the kidneys and the low-density retroperitoneal fat that surrounds them means they are often visible on an X-ray of the abdomen. They lie at the level of thoracal vertebra 12 to lumbar vertebra 3 and lateral to the psoas muscles. The right kidney is usually slightly lower than the left due to the position of the liver. So it's the left kidney. You can see it here. This is the iliopsoas muscle. Spleen on abdominal X-ray. The spleen lies in the left upper quadrant immediately superior to the left kidney. That is the shadow of the spleen. Bladder abdominal X-ray. The bladder has a variable appearance depending on how full it is. It has the same density as other soft tissue structures due to its water content. It's the shadow of the urine bladder. Bones. All bones seen on an abdominal X-ray are better visualized with dedicated images. Nevertheless, it is important to carefully examine the bones visible on an abdominal X-ray because clinically important bone disease may be identified on an abdominal X-ray, either as a significant unexpected finding or as an unsuspected cause of abdominal system. Bones visible on an abdominal X-ray include the lower ribs, the lumbar spine, the sacrum, the coccyx, pelvis and proximal femora. Here are their normal appearances. Normal bones on abdominal X-ray. The lower ribs, lumbar vertebrae and sacrum are highlighted. Bones can be used as landmarks for invisible soft tissue structures. Note the transverse processes of the lumbar vertebra act as landmarks for the course of the ureter's arrowheads. The vesico-ureteric junctions are located at the level of the ischial spines. So it's normal bones. Femur, iliac bone, sacrum with coccyx, pubic bone. Here we see ureters, and we see all the part of the lumbar backbone. Another one. Pelvic bone, sacroiliac joints. They are more dense here. This is no fracture line. This is sacroiliac joint. Sacrum, coccyx, hip joint, and femur. Calcification and artifact. Densities that cannot be explained by anatomical structures are often seen on abdominal X-rays. These may be artificial, for example due to medical devices, or due to soft tissue calcification. This calcification may not be pathological, but differentiating significant calcification from that which can be ignored is not always straightforward. The clinical features must be considered whatever abdominal calcification is suspected. Other investigations may be required. So here we have artifact. Somebody have a scar in its own umbilicus. And here we see Psoas. Try to think, what do you see here? So here we see clamps after surgery, gallstones, and some artifact here. This is part of the lung. Here we see maybe one of possible reasons. It can be fibrosis after consolidation of the lung. Here we see the fluoroscopy. It's residual parts of barium enema that stays in the bowel. This is an example of the MRI of abdomen. Here we see parts of large bowel, its small bowel, free gas in the abdominal cavity we see as a sickle, circle, here and here. Always you must look to the right side, because sometimes it's very difficult to look on the abdominal gas bubble and differentiate this is free gas or this is thin wall of the stomach. So you must look on the right side of the patient. We can see here free gas. What does it mean, free gas in the abdominal cavity? It means we need to perform operation because some organ was perforated. Some organ which contained blood, contained gas. So it was stomach or some part of the bowel. Another sign of the free gas in the abdominal cavity, it's Rigler's double wall sign. In the normal picture we have only one wall visible in the bowel. When we see the Rigler sign, we have double wall visible because we have air in the abdominal cavity and air filling the bowel. When we have ruptured part of the wall of the bowel, gas going out to the abdominal cavity, and we see double wall sign.